Hello, everyone. Welcome to the SSAT webinar on minimally invasive um, treatment for adrenalectomy. Today, we have 5 speakers for you, and each one will have an area of topic that's related to how we handle adrenal diseases and also some of the technical aspect of it. The first speaker is Dr. Linhua Yip, and maybe Dr. Yip, you can show your slides. Dr. Yip is from University of Pittsburgh. She is a chief of endocrine surgery there, and she's going to tell us about non-functioning nodules and malignancies.
Well, thank you very much. And thank you very much to the SSAT as well for inviting us to talk about adrenal nodules. I have no disclosures. So we're going to talk a little bit in the next 15-20 minutes about reviewing the role of imaging and characterization of adrenal incidentalomas, discussing some of the evidence-based recommendations for biochemical screening, and also reviewing indications for surgery and surveillance, which is, of course, the most exciting part of what we're talking about here. So just to start with a case, adrenal lesions in general are very common incidental findings, and that's typically how we identify adrenals, usually through incidental imaging. And so, for example, this is a 67-year-old woman who had a left 3.3 centimeter adrenal mass that was seen on imaging obtained as part of a peristomal hernia evaluation. I saw her maybe about 4 to 6 weeks ago. So adrenal incidentalomas in general, asymptomatic adrenal masses detected on imaging performed for a non-adrenal reason. These were initially described in 1982. The original definition did not really include a size cutoff, but currently many recommendations do limit the definition to adrenals that are greater than 1 centimeter. The prevalence is age dependent, so overall it's about 2% in autopsy studies. Recent studies suggest that perhaps we see these in about 4 to 5% of all patients who have a CT or MRI. And this is a beautiful graph. I like this graph because it very nicely shows stepwise by decade and age the incidence or prevalence of adrenal incidentalomas. And so I carry in my head that it's about 7% in patients who are older than 70. The differential diagnosis is that most of these are adenomas. You'll hear a little bit more in the next hour about the detection of autonomous cortisol secreting masses, aldosterone secreting masses, and pheochromocytoma. What we, of course, don't want to miss is adrenal cortical cancer. In all patients, it's about 0.5% to 4%. Obviously, the prevalence is much higher in surgical series. And of course, we don't want to miss adrenal metastases either. Many of these are identified in patients who have an existing history of cancer, but certainly sometimes this is the presenting finding. And so the initial assessment usually revolves around a functional assessment, and this can often be guided by history and physical, but mostly there's a standard biochemical evaluation, which we will talk about in a second. And then ultimately, we decide malignancy risk based on imaging features, and we'll review some of those findings in a minute as well. I like this graph. This came from this figure from Fasnacht et al. This is the European Society of Endocrinology. It's their adrenal incidentaloma recommendations. What I like about it is that it really kind of highlights that you're doing both of these simultaneously. So you're assessing for malignancy as well as whether or not these are functionally active. And really, while we want to aim at the establishment of a definitive diagnosis, sometimes we just have to play our odds a little bit and hopefully can follow some nodules with low risk with surveillance. So from a functional status standpoint, it really revolves around the history and physical. Unfortunately, this is sometimes helpful, but certainly not super specific or sensitive. I think the main thing that I wanted to highlight here is that many symptoms overlap. In particular, all three of these hormonal excess syndromes really are characterized by hypertension. Certainly headaches, palpitations, things like that are very common among many of our patients. But I think the other notable thing to think about is that there are 10 to 15% of patients who don't have symptoms at all. And so that is really why functional status is really often done routinely for many adrenal nodules. And this is a little bit of a busy slide. You can, highlight it and come back to it later. But it really, the initial biochemical assessment, really what kind of hormones we're looking at is seen over here on the left side, who needs to be evaluated, what is the test that needs to be done, and then some additional considerations over here on the right side. Now, I'm going to put in a shameless plug. This can also be found in the AAES adrenalectomy guidelines, which was published 2 years ago in JAMA Surgery. Both Dr. Du and myself were authors on this on these guidelines, but this is a truncation of that of a table that's in there. I think the key things are that all patients should be assessed for adrenal hypercortisolism. The most sensitive test is a 1 milligram overnight dexamethasone suppression test. I usually will check an ACTH and DHEAS at the time of their presentation as well, just to make sure that we're really looking at adrenal cortisol, hypercortisolism. For primary hyperaldo, usually hypertension in patients with or without hypokalemia. This hypertension, probably every one of our patients has some degree of hypertension, and so it's really part of the initial screening. Some of the changes that have happened recently is that not all patients necessarily need screening for pheochromocytoma, only if the mass on imaging has a Hounsfield units of greater than 10. So lipid, and we'll talk a little bit more about these imaging features in a little bit, but lesions that have a Hounsfield unit less than 10 do not need pheochromocytoma screening. And then you can see the recommendations here for androgen and steroid precursor. And so ultimately, a lot of the initial assessment relies on imaging and assessment of imaging features in order to assess whether or not we need to be concerned about cancer. And so we all know that we all carry around in our heads that larger sizes associated with ACC. There is a lot of data to support that. This is one of the earlier studies by Sturgeon et al. He looked at adrenal adenomas that were resected at his own institution and compared the size to a database of adrenocortical cancers, and really came up with these sort of likelihood ratios. So again, you can see at 4 centimeters, the likelihood of there being cancer is about twofold baseline, and that comes up to about 10%. And so that's where those numbers come from. This has subsequently been confirmed in other studies. This is a large single institution study from Cleveland Clinic, over 2,000 adrenals over 7 years. Many of these had greater than 12 months follow-up, but only a fraction of them went to surgery, as you can see here. But again, you can see that size was associated with ACC. In their series, over 4 centimeters was associated with a 2.4% risk of cancer, while over 6 centimeters was associated with a 20% risk of cancer. So really confirms this sort of dogma, I guess. In their analysis, they did an ROC analysis. Anything over 4.6 centimeters had this sensitivity, specificity, and AUC, so pretty predictive for cancer. So that's why we take out large nodules. Now, there are some exceptions, and I think these are important to know. So first of all is an adrenal cyst. Adrenal cysts are characterized by having washout that's unchanged on adrenal particle CT. Sometimes we take these out if they're symptomatic, but generally, if they're truly a cyst, and you have to make sure that, because there can be cystic cancers, you really want to make sure this is really characteristic of a simple cyst, and your radiologist should be able to let you know that. In addition, a myelolipoma is also large, but is almost always benign, and these can often be followed by imaging surveillance. Now, there again, you have to be very careful. There can certainly be sarcomas that can mimic myelolipomas, and so I usually do follow these just to make sure that they are stable in size. In addition, I like to see that there's really sort of this relatively homogeneous fatty low density Hounsfield unit within the mass. If there's any area that looks like it's heterogeneous or a little bit more dense, then I tend to get a little bit more concerned that maybe this could be something besides just a plain old myelolipoma. So these don't usually need surgery, but you just have to be very careful about assessing these accurately before you make that decision. But we really rely on imaging characteristics. So this is based on the fact that lipid-rich cells have low attenuation on unenhanced CT scans, and we use this for both CT, the same principle, as well as in MR imaging. And the two sort of catchphrases that I like to see are Helmholtz units less than 10 on non-contrast CT. This is highly sensitive and specific for a benign adenoma. And then on MRI, you like to see this loss of signal on chemical shift or out of phase imaging. This is also looking at similar features, which is looking at the proportion of lipid cells within the adrenal. Adrenal protocol CT scan is runs by the concept that adenomas rapidly take up and lose IV contrast. Carcinomas also rapidly take up, but they are slower to wash out. Pheos can often mimic either adenomas or carcinomas, and so really you can't really rule out a pheo using this adrenal protocol CT. Washout is typically calculated using pre-contrast Helmholtz units, 60 seconds after injection and 10 to 15 minutes post-contrast. Although these are fairly standard protocols, there can be some variability which can affect some of the studies, which I'll talk about in a second. And so we like to see this rapid washout, relative washout greater than 40% or absolute washout greater than 60%. And this is typically often helpful in terms of characterizing usually slightly more lipid, potentially lipid poor adenomas. So we define indeterminate features when it does not meet these washout criteria, or if it has a Helmholtz unit greater than 20 on a non-contrast CT. And there have been a number of different studies that have shown that these two features, again, we classify these as indeterminate features, that these have a higher risk of cancer because, again, these other, they exclude the fact that these are lipid-rich lesions. But it's controversial, and I have to say that it's been a moving target, to be honest. Not all studies use histology as a gold standard, so there are a lot of studies that use biopsies of adrenals to confirm benign lesions or stability on interval imaging that's less than 12 months, so maybe not completely benign. A lot of studies include non-incidental patients with prior history of malignancy who may have a higher pretest probability that this lesion is malignant. Pheochromocytomas, like I said, can often mimic either cancer or adrenal adenomas on adrenal protocol CT, and so you really have to be careful looking at the studies that you're including the right nodules. In addition, some studies, especially some of the more recent ones, what is malignant? It can really be a little bit fuzzy. Some of those studies include pheos in that sort of the non-ACC malignant category. They can include atypical adenomas or oncocytic adenomas, and so it becomes a little bit of a waste basket in terms of what's considered non-benign. Imaging interpretations are non-blinded, and so certainly there may be some skewing of those results. And like I mentioned before, there's certainly different protocols for washout as well. And this is really highlighted. This was an attempt at a systematic review and meta-analysis performed by people within the European Endocrinology Society. This was done in 2016. And you can see they tried to look at all the different washout features and the different types of studies, MRI, PET scan. And they basically concluded that the studies are just highly heterogeneous and disappointingly poor. This word disappointing really is in multiple parts of this paper. And really the only thing they could really conclude is that this greater than 10 Helmholtz units for detecting malignancy is high. So if you have an adrenal lesion that's less than 10, the likelihood of this being cancer is exceedingly low. And that's all they could really say. So I think we need to do better from an imaging standpoint to really guide our management. Certainly, if you take out everything that's over 10, you will never miss a cancer, but you're going to be taking out a lot of benign adrenal lesions. And so I think we just need to be a little bit more thoughtful about what we're doing there. So PET scan has been looked at as well. And so in this particular study, it had fairly good sensitivity, specificity, PPV, and MPV. PET scans, as we all know, are not super cost effective. And so I'm not sure that this is the ideal way to screen and decide who needs surgery either. And so I think, thinking about, stratifying how to determine malignancy risk of an adrenal lesion by imaging, in my mind, I kind of think about low to none. You know, we talked about that low Hounsfield units and the size, small size. This intermediate risk group really encompasses larger nodules, things that really have indeterminate features, including heterogeneity on non-contrasty CT scan, and then of course high FDG avidity on PET scan. And I think the really high ones, these are ones that are like kind of no-brainers. They're big and they have at least one of those indeterminate imaging features. I think these are ones that we definitely want to take out. And of course, if it has local evasion, then these patients will, we know that this is cancer, and they, should go to surgery. For these low to none, I think both the adrenalectomy guidelines from the AES as well as the European guidelines really suggest that if it's small and has these low Hounsfield units, that really no further surveillance is needed. I think, again, there are pitfalls with just really making sure that you're getting accurate Hounsfield units measurements on your imaging, and hopefully your radiologist should be able to guide you with that just to make sure. If it's in that indeterminate between 10 and 20, we think most less than 20 are likely going to be benign, but there are some between 11 and 20 that could potentially fall into kind of a false negative category. And so at least a repeat imaging would be a good idea. For these indeterminate lesions, if the patients aren't really great candidates for surgery, then I think repeat imaging or surveillance would be a good idea. But really, if they're decent candidates, I think surgery is a very reasonable option to talk about with for these nodules. So surgical indications are functional nodules. Certainly if there's any concern about some of the functionality, and I'm sure some of our speakers coming down will be able to give us more insight about this. They should really strongly consider maybe some multidisciplinary input. Bilateral adrenal nodules or hyperplasia, people who have cortisol levels that are kind of in the indeterminate range, and of course, some of these other more complicated hormone issues. Large adrenal lesions, except for cystic myelolipoma, should probably come out. And then, of course, when imaging is not consistent with benign adenoma, as we talked about, thinking about if this patients have extra adrenal malignancy, then that's a reason to potentially take it out, accounting that the comorbidities and frailty really allow for adrenalectomy. And of course, if patients can't undergo surveillance, then that would be an indication for surgery as well. Surveillance for non-functional adrenal lesions, really less than 10 Hounsfield units on non-con, and the small lesions, really no further imaging is required. Ooh, excuse me. Otherwise, repeat imaging in 6 to 12 months. I usually use a non-contrasted CT, we're really looking for size, or MRI. The current recommendations are if it grows more than 20% or greater than 1 centimeter increase in diameter, to consider taking it out. There's really no data whatsoever to support this, but I guess we have to make a recommendation somehow. In general and natural history databases, about 5 to 25% will enlarge, some will decrease in size, and certainly you can repeat the functional evaluation if there's any new clinical signs. So for our patient, I'll just go through this quickly. She was a bit complicated. She had IBD, had prior total proctocolectomy and ileostomy. She had this stomal redundancy, but this ended up being she had some symptoms that were concerning, although she didn't have hypertension. We did the routine evaluation for her. I recommended a CT of the abdomen adrenal protocol. She actually had elevated metanephrines, so this was an incidentally noted diagnosed pheochromocytoma. And so she had this CT scan, and you can see this is a non-contrasted CT scan. This is a heterogeneous lesion, and so it really didn't meet criteria to be assessed by Hounsfield units, but there you go, it's 14, and so it kind of fell between that 10 and 20, so in that indeterminate range, but really this was a heterogeneous lesion, so it should have come out anyway. So she ended up getting this taken out. It was a confirmed pheochromocytoma, and she felt better. So in the last 2 seconds, I'm going to make a shameless plug again for the AES guidelines published in October 2022. 26 evidence-based recommendations, multidisciplinary, really, really fantastic body if you want to just reference a quick, sort of look at adrenalectomy surgery, guidelines for surgery, sorry. So in summary, adrenalectomy when functional, large and or imaging indeterminate, otherwise surveillance, and then really no data in terms of when to stop the surveillance, but generally at least 6 months and 12 months. And then if you have any concerns, then you can certainly carry that out further. All right.
Well, thank you very much, Dr. Yip. That was a tour de force of a review of adrenal tumors. And thank you very much. I just want to make sure that people in the audience, if you have any questions, go ahead and put it in the Q&A. And we should have time to do some Q&A either individually or later. Next up, we have Dr. Adriana Ramirez from Yale University. And the topic is going to be on Cushing's syndrome and aldosterone. So, Dr. Ramirez, please go ahead.
Okay, can you hear me now? Hopefully I'll take your silence as everything is okay. All right, so Cushing syndrome and hyperaldosteronism are both disorders of adrenal hormone excess. Most commonly, these are associated with benign adenomas originating from the first and second layers of the adrenal cortex. Cushing syndrome or primary hypercortisolism have a prevalence of hypercortisolism, yes, is a prevalence of 2 to 3 per 100,000, while hyperaldosteronism has a prevalence of 1 to 10 per 100,000, though this increases to upwards of 10% in patients that are hypertensive. The two most common patient referral presentations to our specialist clinic really are the adrenal incidentoloma with variable biochemical workup, as Dr. Yip mentioned, or abnormal laboratory testing with or without cross-sectional imaging. So the purpose of the initial consultation for patients suspected of Cushing syndrome or hyperaldosteronism should really focus on ascertaining the diagnosis through initial screening and confirmatory testing, followed by dedicated cross-sectional imaging for localization plus or minus adrenal vein sampling interpretation prior to a discussion about perioperative management and considerations. Okay, so I just wanted to start off with a recent case of mine from clinic. This is a 42-year-old female, previously healthy until a few months ago. Following her hysterectomy, she developed weight gain, agitation, diffuse acne, proximal muscle weakness in her bilateral extremities. She was also noted to have new onset hypertension, worsening hyperglycemia without a prior history of diabetes, central obesity, prominent stria on her abdomen and moon facies. So when she came to me, she had these initial labs and from her OBGYN. Most notably, she had a random fasting AM cortisol of 36. However, this was not done after taking steroids the night before. So this is just a rough and ready algorithm of how I think about the evaluation of a patient with hypercortisolism. After obtaining my history and physical, my go-to screening test, as it is the most sensitive, is the low-dose dexamethasone suppression test. I do that with either a concurrent dexamethasone level or a random ACTH performed prior to the DST. If the cortisol fails to suppress, that is a positive screening test. I then proceed with confirmatory testing, and that can be either a repeat DST, which normally I do with a higher dose of dexamethasone, usually 2 milligrams instead of 1 milligram, or you can do a 24-hour urine-free cortisol level or multiple late-night salivary cortisol tests. Also, at that time, I ordered dedicated cross-sectional adrenal imaging, either with a CT or MRI if it's not been previously obtained. And finally, if at any point I have cross-sectional imaging with evidence of an adrenal mass, I will complete the remainder of the biochemical workup. In this case, that would be serum aldosterone levels with plasma renin activity and plasma reninephrines. All right, so I recommend if you are concerned about the interpretation of these tests that you do engage with your endocrinologist. These tests can be affected by stress, depression, anxiety, obesity, pregnancy, infection, as well as numerous medications, particularly in the case of hypercortisolism, that's oral contraceptives or estrogen therapies, anti-epileptics, and antidepressants. There are essentially 4 possible outcomes of your biochemical workup. You can have a negative test for hypercortisolism, so you initially just had a false negative. equivocal results or erroneous testing, so you have to repeat your testing again. You can also have mild autonomous cortisol secretion, or MAX. This was previously also called subclinical hypercortisolism, or you can have overt cortisolism, and that's your classic Cushing syndrome. This does then have to be further characterized in the presence of a unilateral adenoma, bilateral adrenal nodules, or hyperplasia, or in the cases of an indeterminate nodule, which should raise suspicion for an adrenal cortical carcinoma. In this clinical scenario, that you had your screening DST showed a non-suppressed cortisol with an appropriately high dexamethasone level and a low or normal ACTH. I ended up doing 2 confirmatory tests, a 24-hour urine cortisol, which was normal, and then I repeated the DST, and that remained non-suppressed. So a cortisol level that was between 1.8 and 5. The rest of the biochemical workup was normal in the dedicated CT. As you can see by the arrows, showed a 4-centimeter left adrenal mass consistent with an adenoma. This is most suggestive of mild autonomous cortisol secretion. In these cases, the cortisol level, as I said, would be between 1.8 to 5 with proper stimulation. One of the primary reasons I kind of shifted between away from doing a 24-hour urine cortisol for this is, and even actually as my confirmatory testing, is that this will be normal in MAX. So second scenario, instead you have an elevated cortisol level that's greater than 5 with a concurrent high dexamethasone level and a suppressed ACTH. In this case, confirmatory testing can be either a 24-hour free urine-free cortisol or repeat DST, which will show an elevated cortisol in either case. The rest of the biochemical workup is then normal. Imaging, again, is consistent with a unilateral benign appearing adenoma. And this is overt cortisol secretion or Cushing syndrome. In cases where the ACTH level is high, then you do have to consider ACTH-dependent sources, which would be pituitary versus ATH-producing tumors, and not the focus of today's topic. Finally, kind of same scenario as previously. The only exception is that on imaging, you have evidence of bilateral adrenal nodules. However, this would still be considered overt cortisol secretion. So expanding on the previous algorithm to include when you would recommend patients for surgery, in patients with unilateral adenomas with biochemical evidence of MAX, and they have one of or more of the following, that would be refractory hypertension, diabetes, glucose intolerance, osteoporosis, fragility, fractures, worsening metabolic syndrome, high cardiovascular risk, or an adrenal greater than 4 centimeters. I do offer adrenalectomy for these patients. Patients with unilateral disease with overt Cushing syndrome should also have surgery if they're appropriate surgical candidates. And in the case of bilateral nodules, I do perform adrenal vein sampling. I'll get into the interpretation of the adrenal vein sampling with aldosteronism in more detail. But essentially, if they lateralize to one side, I do recommend surgery. There are nuances as to how to interpret an AVS, since it's not very frequently done for hypercortisolism. There is consideration to removing the more biochemically active gland for partial improvement of symptoms versus removal of the larger gland. Rarely bilateral adrenalectomy can be considered, but this should really be decided in a multidisciplinary setting. So regardless of cortisol excess activity, patient optimization of blood pressure and glucose control does have to be done preoperatively. So patients with MAX, the contralateral adrenal may not be suppressed, may be suppressed, but to a variable amount, and may or may not require postoperative steroids. So I typically perform a cosentropin stimulation test on post-op day 1, and I do wean their antihypertensives and diabetes medication is tolerated. Patients with overt hypercortisolism, I will give them routinely intraoperative stress dose steroids with hydrocortisone, ideally within 1 hour of the division of the adrenal vein to combat the expected adrenal insufficiency of the suppressed contralateral adrenal gland. These patients subsequently go home on a gradual steroid taper with short follow-up with their medical endocrinologist. Moving on to case number 2, and hyperaldosteronism. This is another patient I saw in clinic, a 28-year-old female with hypertension. She was postpartum and had been kind of discharged from the hospital with 2 agents. She later subsequently developed, she presented to the ED with bilateral lower extremity weakness after she discontinued her meds completely on her own. Potassium at that time when she presented was 1.7, and she did have associated EKG changes consistent with hypokalemia. Nephrology did most of her initial workup. At that time, she was found to have an elevated aldorenin ratio greater than 30. In this case, it was 300. And they performed an oral salt loading test as her confirmatory testing. So 3 days of high dose oral salt intake, followed by a 24-hour urine collection of aldosterone, which in her case was also high. So as with hypercortisolism, history and physical, followed by screening confirmatory testing. In the case of hyperaldosteronism, screening is really the aldo and renin ratio. Values greater than 30 are considered a positive screening test. Additionally, an aldosterone level greater than 10 or 15 with a suppressed renin, which can be variable, but I think most people would say an aldo greater than 15 is a positive screen. Subsequently, there are several confirmation tests to choose from. So the oral sodium salt loading test, the saline infusion test, the fluorocortisone suppression, and the captopril challenge test. Patients subsequently do get dedicated cross-sectional imaging of their adrenal. CT or MRI is kind of the preferred go-to. And then I refer these patients for adrenal vein sampling. There is a bit of controversy whether patients less than 35 years of age with a unilateral adenoma on imaging need an AVS. I routinely request an AVS, particularly as aldosecreting tumors are small, can be less than 1 centimeter versus hyperplasia. And again, with any evidence of an adrenal mass or possibility of surgical intervention, I do complete a biochemical workup as shown here. So patient was found to have a 1.8 right adrenal adenoma. Other possibilities would include bilateral nodules, bilateral hypoplasia, and rarely an aldosterone secreting ACC. All right, adrenal vein sampling. This is used to determine lateralization of hormone secreting tumors. Most commonly, it's used for aldosteronomas. So depending on your institution, the AVS can be concentropin stimulated, either with a continuous infusion or bolus, or it can also be unstimulated. The main difference between the two is that you need higher cutoff values if it is stimulated, but this is considered to be more specific. So on the right are the results for our patient of her particular AVS. She had simultaneous collection of cortisol, aldosterone levels from her IVC, her right and left adrenal vein at various time points during the procedure. So the first step after you get the raw numbers is to confirm successful cannulation. So that's done by calculating something called the selectivity index, which is adrenal cortisol over the IVC cortisol for the left and right adrenals. The selectivity index does need to be at least 2, excuse me, because it's a ratio for unstimulated and 3 for stimulated. The lateralization index is a ratio of ratios. So you need to calculate the aldosterone to cortisol ratio for each adrenal vein. The lateralization is then the ratio of the dominant side over the non-dominant side. Accepted values for lateralization can vary, but the most commonly used is greater than 4. Suppression of the contralateral gland can also be calculated by simply flipping the ratios with a value of less than 1 indicative of suppression. So that would be the non-dominant over the dominant ratios. As I mentioned, AVS can be used for cortisol secreting masses. In that case, it's performed and calculated in a very similar fashion by substituting cortisol for aldosterone and calculating the cortisol to aldosterone indices. So in summary, surgery is recommended in cases of unilateral disease for hyperaldosteronism. Bilateral hyperplasia is generally treated medically and managed non-operatively. Considerations revolve around really electrolyte management and fluid status. These are focused on correcting any hypokalemia and optimizing the patient's blood pressure. Most patients are started on mineralocorticoid receptor antagonists. Spironolactone, and eplerenone are the most common. To address both of these abnormalities, intraoperatively, they do require electrolyte monitoring and judicious fluid resuscitation with the expectation that they could have significant blood pressure fluctuations following the division of the adrenal vein. And then postoperatively, they can have rebound hyperkalemia. And so it's important to stop their potassium supplementation. I also begin to wean their blood pressure medications prior to discharge. I usually tell them that about 30 to 50% are going to have a complete resolution of their hypertension, but this obviously depends on a lot of factors, including age, time of medication, sex, etc. However, most will have some improvement in their blood pressure, so I do go ahead and start to tailor those off. And that is all I have.
Well, thank you very much, Dr. Ramirez. I think we would have some questions for you afterwards, and I'm sure we will continue with this. Next up is Dr. Patel, Chanel Patel. We'll be talking about pheochromocytoma. Dr. Patel is from Emory, so go ahead, Dr. Patel.
Perfect. Thank you so much. And thank you to the SSAT for organizing this webinar. I'm going to break down pheochromocytoma and kind of focus on all the pre-op workup and what's needed to get these patients ready for surgery and also the management of them afterwards. I have no disclosures, just a brief history because I think PHEOs are very interesting. So it was first described by Felix Frankl in 1886, made the association between adrenal medullary tumors and the typical symptoms of a PHEO. And in that, he described this 18-year-old female with the classic attacks of palpitations, anxiety, headaches, chest pain, cold sweats, and found the bilateral adrenal tumors on autopsy. And so that's where these catecholamine secreting tumors that arise from the chromaffin cells of the adrenal medullas. And it's the chromaffin cells that are actually called pheochromocytes. It's the catecholamines that's released, so epinephrine and norepinephrine, which is synthesized and stored in the adrenal medulla, and then released in circulation, and then dopamine, which is also found in the adrenal medulla and the peripheral sympathetic nerves. It's these catecholamines that affect the cardiovascular and metabolic processes that increase the heart rate, blood pressure, myocardial contractility, and cardiac conduction, and is stressful stimuli that triggers these the secretion of the adrenal medulla. So what we think of when we see the classic presentation is this classic triad of headaches, palpitations, and diaphoresis. So when we see all three, it has a 91% sensitivity. But oftentimes we won't see all three, but this is kind of the classic PHEO symptoms and classic triad. But most of the presentations, I'll be honest, are outside the classic triad. So most of the patients present just very non-specific symptoms. They have minor or they're even asymptomatic. The differential is very large. And so majority of the time, PHEOs are not considered. So as Dr. Yip kind of broke down the adrenal workup and non-functional, I'd say majority of the time, those are how these are found. And so when we break down the clinical subtypes, you have the sporadic form, which are generally the 40 to 60-year-olds that are isolated just to the adrenal glands. And then we have to keep in mind the familial syndromes, which are younger in age and are often bilateral in involvement. And then the extra-adrenal tumors. So these patients will be younger, they're rarely familial, but often multifocal. And PHEOs can also be malignant, so it'll correlate with size, and they're more likely higher if they're extra-adrenal. So which patients do we screen? So patients that come in and oftentimes are referred to as already with the diagnosis, but not always. So if they have episodic attacks of classic symptoms or any family history of pheochromocytoma, VHL or paraganglioma syndrome, those patients should be screened. And then all adrenal incidentalomas should be screened. And then these patients that are having these paroxysms of hypertension or arrhythmia with activity. And the last one, always keep in mind the medullary thyroid cancer patient. So all the MEN2As or any patient with, medullary thyroid cancer should be screened for a pheo. So I think the most confusing part that we see for people is what is the most sensitive biochemical screen, and a lot of excess workup is not necessarily needed, and hopefully kind of getting that from this webinar. So if you look at just plasma-free metanephrines, the sensitivity is going to be the highest with just plasma-free metanephrines, and similar with the if you do a 24-hour fractionated metanephrine. So either or is equivocal in terms of the sensitivity, and the specificity sits around 85%. So it's easy when the elevation is greater than 4x. But what do you do when you have these mild elevations of 2 to 3x? Well, the first step is just to repeat either one, the plasma or the urine, but just keeping in mind that there can be interfering medications and actually optimizing these patients. So some of the ones are actually just stopping their caffeine or chocolate, Tylenol, nicotine, tricyclic antidepressants, and then the proper way to actually draw the metanephrines is to actually get an IV, place them lying down in a quiet room after they're fasting, and then once they're relaxed, draw the blood so you don't spike the metanephrines. That's very difficult to do, I'll say, so we don't always do that. But the first is, do you have a clinical suspicion of pheos or paragangliomas? And if so, then whether it's based on an incidentaloma or just on history and physical, then the plasma-free or urine metanephrines, if they're both normal, then it's ruled out and tumor unlikely. If they're elevated, then it's what degree of elevation. So I think this is important. If it's greater than 3 to 4x the upper limit of normal, then proceed to localization studies. But if it's less than 3 to 4 times the upper limit, then really go down this route of what is it or what do we do? And if you repeat it, it's normal, then it's ruled out. But if it remains elevated, then continue to kind of push on. And at the end of it, this is a clonidine suppression test. But I think most of us would probably just go to imaging at that point if the suspicion is still there with this mild elevation. So really it is the initial screening is the plasma-free urine metanephrines, and just keep in mind it has a 15% false positive rate. But if it is negative, pheos are excluded, and really these multiple biochemical studies are not necessary. I thought I would plug this in for Dr. Du from this is the subclinical pheos and their experience at UCSF. And it's interesting because it really, he looked at the adrenalectomies over 1995 to 2005, and the pheos, they had 33% pheos. But what I really is this what to do with these borderline elevated metanephrine. So it's 1 to 2 times the upper limit of normal. And of those patients, 30% had a pheo. So and they're all asymptomatic, right? So even when you go back and you ask the questions and you screen, we're not getting symptoms. So unless they truly have a significant elevation in their metanephrines, which we don't always see, most people are truly asymptomatic. And so so it is interesting to keep in mind that it's not excluded, and these borderline ones can still be pheo. So take that into account with imaging when we operate. And so that goes to, what do you do next, right? So imaging, it'll follow the biochemical confirmation, or in the case of this 1 to 2x elevation. And as Dr. Yip mentioned, CT, but for pheos, MRI has the highest sensitivity with the T2 uptake on it. And so both of these will have the highest sensitivity for the pheos. The role of MIBGs, it's not necessary, especially if you're, so the times that we'll get an MIBG are if you're worried about extra adrenal tumors, more familial or malignant. But if it's just a single adrenal pheo that you're worried about, we don't need an MIBG. And I know oftentimes patients will come with an MRI and an MIBG and a dotatate, and that's not necessary. And now the dotatate scans, again, I think are in my opinion, are really kind of starting to replace this MIBG for localization and with a higher sensitivity. So I think the alpha blockade is probably the most important to get the patients, and I think is a part that I just want to focus on because we tend to do these ourselves because we're in the operating room rather than relying on endocrinologist or PCPs to really block the patients. Since I feel like we have a better understanding. It has become harder since back when we were using phenoxybenzamine and it's not available. If you're able to get it, then it's easy, and you start with 10 milligrams and you titrate up based on orthostasis. But generally, I tell patients it takes about, you need a minimum of 2 weeks to get them ready for surgery. 2 to 3 weeks is great. And if you do this, you can beta blockade is really not needed, but really only after you have sufficient alpha blockade, and that doesn't prevent any hypertensive crises in the OR. What keeps their heart rates down as you titrate them up is having them stay hydrated and increasing salt intake. This is just a picture of a pheo that was invading into the IVC. And so these patients will be symptomatic, as you can imagine, when they're larger or more invasive. So what have we done since phenoxybenzamine is not commercially available? I think I've maybe blocked once in the last 10 years with phenoxybenzamine. So calcium channel blockers, nicardipine is a great alternative. It has way fewer side effects, but it's hard to really track their orthostasis. But it does translate well to the OR in terms of IV nicardipine and intra-op response to the hypertension. And so they respond better to volume expansion intra-op as well. So what a lot of folks do, and what we've done is using an alpha-1 selective like doxazosin and starting at 2 milligrams and titrating up for blood pressure and checking their orthostatics daily, and then adding on a calcium channel blocker. I usually do that about a week prior. So the combination of the two has worked really well in terms of preparing these patients, just since we're not allowed to see phenoxybenzamine anymore. The genetics part is, is just almost 15 years ago, it was thought that only about 10% of all these paragangliomas and pheos were genetically determined, but many more susceptibility genes have been identified, and so now we're talking about it to explain almost half the cases. And when you look at the chart for genetics, anything from NF1 to the RET oncogene, VHL, and obviously the SDH mutations, have all been associated with pheos and paragangliomas. So then who do we screen for genetics? So any family history, young age, so anyone 20 or younger, and then if they have bilateral or multifocality and the presence of paraganglioma or other tumors, and really about 25% of patients will have a pheo, with a pheo will have this associated familial syndrome. So genetic testing really should be considered in these patients. That's all I have. And I think if you have any questions, please let me know, especially about the alpha blockade and getting these patients prepped for surgery.
Okay, thank you very much, Dr. Patel. That's a nice review of pheochromocytoma. And so now we have reviewed all of the endocrinological workup. We're going to go on to some technical aspect of minimal invasive adrenalectomy. First up is Dr. Felipe Magawa for robotic adrenalectomy. Please go ahead, Dr. Magawa. You may have to unmute first.
Sorry about that. Good evening, everyone. Thank you for joining us tonight. I will be talking about robotic adrenalectomy. We'll be sharing some videos showing our experience, some straight cases that can describe well our technique, and some more complex cases where I think the robotic platform with the articulation and visualization comes into play. So let's get started. I have no disclosures. So what does the data show? So robotic adrenalectomy, when it's compared to laparoscopy, has been associated with some clinical benefits. I picked the 3 studies here, the most recent ones, and there is a large one, propensity score matching with patients from 46 centers in Europe. It shows that robotic approach was associated with less risk of a serious complication. There is a clinical trial actually from Dr. Ma from China. He had 70 patients in each arm show that robotic compared to laparoscopic surgery was associated with less blood loss, shorter operative time, and however, there was increased cost associated with that. Laparoscopic versus robotic adrenalectomy also has been described single center experiences throughout the United States. And besides the benefits that I already described, the other ones are a shorter length of stay, lower conversion to open, and lower positive margins if you're operating for cancer. For those who are interested in starting to do robotic adrenalectomy, I think the next couple of slides are probably the most important. I think 50% of the effort is patient positioning and trocar placement. I think if you get those right, I think you set yourself for success. Here's the patient positioning that we use. We have a full lateral decubitus, both for right and left adrenalectomies. As you can see, the bed is flexed. We have the subcostal margin kind of on the crack of the bed to expose the angle between the costal region and the iliac crest. So you want to open that space because that's where the trocars will be. And as for a standard patient's lateral decubitus, they're secure with a beanbag, safety straps, and the pressure points are padded. Here's our trocar placement. I put these 2 pictures next to each other because they're pretty much the same, right and left, same trocar placement. They're pretty much a mirror of each other. We enter the abdomen through a lower quadrant optic view with a 5mm optic view. And the first trocar we place is the further lateral, the one that is in the posterior axillary line, because that trocar mobilization laterally is limited by the colon. So you put that one first, and then you march towards the xiphoid process, keeping a space of 6 to 8 centimeters between each trocar. And usually we put like about 1 to 2 centimeters below the costal margin. So you want to be high because you'll be surprised how high the adrenal gland is, especially on the right side. And you want to look down instead of looking up so that your most lateral trocar doesn't hit the iliac crest and you kind of limit the range of motion for you. Routinely for the right adrenalectomies, we upsize the 5mm trocar to a 12 just to have easy access to put a baby lap and put pressure in case of bleeding. We have that as a setup for bleeding, so we know exactly what to do in an environment of stress if that becomes an emergency. Knock on wood, we didn't have to do that, but we have a system set up in case we need. So this is our OR setup. So we dock always from the right, just because that's the way the robot's parking our ORs, but it doesn't really matter. You can see both right and left, we dock from the right side. The only thing you have to set up the robot to patient's upper abdomen. So next, I'm going to show some videos here from our experience. The first one is kind of a more straightforward right adrenalectomy. So we start the case. We're mobilizing the right lobe of the liver. So we use that tip up on the xiphoid process to hold the right lobe up. And then we take the coronal ligaments and we mobilize the right lobe of the liver to rotate the liver medially. This is the peritoneal above the adrenal gland and nodule. They're kind of mobilized. Once we have that mobilized, we readjust our retraction. We like to use a ray tag to hold traction of the liver and also some padding. So we open the groove between the IVC and the adrenal mass and nodule there. And in this case, it was a 5-centimeter nodule, pheochromocytoma sitting against the renal vein. So we expose the confluence of the renal vein and IVC. And we keep on this meticulous dissection layer by layer so we don't have bleeding obliterating the areolar plane there. It's easy to find the adrenal vein if you have that plane intact. So now dissecting under the adrenal vein, we go on top so we can see the tip of the scissors around. So we encircle it. And we routinely like to control the adrenal vein with a hemolock towards the IVC, in this case, a medium large. And then we vessel sealer and divide the adrenal vein towards the gland with the vessel sealer device. And after that, we just dissect circumferentially, taking the retroperitoneal attachments. Here, because this patient had the mass attached against abutting the renal vessels, we took some of the gerotas so we could expose the renal vein and artery. There's the renal artery comes into view next to the renal vein, and we take everything cephalad to that, along with gerotas and the mass. We then go back immediately, take some of these posterior attachments. Remember, we're fully lateral, so we're looking at the posterior aspect of the inferior vena cava. Then we take these retroperitoneal attachments here with the vessel sealer because of the adrenal arteries. They're going to be there, so we like to seal those arteries, the little ooze from the retroperitoneal. Then once you take the inferior attachments here, the vessel sealer freeing the gland and the mass from the renal vessels, we just lift the gland up, and then you can have a good view of the retroperitoneal, and you kind of mobilize cephalad. You have to be careful with the mobilization of the gland. We try to avoid the rupture in the capsule, so we just kind of put some pressure. We don't grasp the gland or the mass. Sometimes helpful to have a ray tag to do that. So we just go cephalad and then all the way up, and then you're free. Just checking for hemesthesia here. The clip is in place. We dab with a ray tag. Make sure everything is hemostatic and nice. So that's the first video, more straightforward. The next videos are some videos of patients that had some complexity on their cases. This one, the adrenal vein was draining into a right hepatic vein instead of draining into the IVC. So we recognize that early on during the case. So the good visualization helps with that. So here we're kind of taking the peritoneal of the gland, creating our dissection under the adrenal vein that is going to that hepatic vein. It's the same procedure. Try to stay as hemostatic as possible to keep the areolar plane. Once we are around the adrenal vein, then we control in a similar fashion. So we dissect cephalad first, so we go around with the scissors, we see our tip, and that prevents us from poking a hole posteriorly on the IVC, or in this case, the hepatic vein. So hemolock, then go with the vessel sealer. I took in a few bites in this case because we didn't have complete mobilization cephalad, and we can do that because we have a hemolock on the hepatic vein. So we took a few bites, and then because we like to do a finer dissection, we go back to the scissors. And then here I use the ray tag to put pressure and retract the gland down so we can see the superior limb of the gland and take that off of the liver, and so we can go around and free completely the gland and have a full mobilization to get the medial aspect of the gland with the vessel sealer. So definitely the visualization, articulation definitely helps in this case. Show another right adrenalectomy here. This patient had a subclinical Cushing's and have a large hepatomegaly. As you can see, the tip of the liver is all the way to the pelvis. So it's a very difficult mobilization. So we take our coronal ligaments and then we place our tip up to hold the right lobe of the liver up. As you can see here, the liver is very bulky and the liver edge is pretty much on the trocars. We had to pull back a little bit so we wouldn't traumatize the liver parenchyma. Standard technique, mobilize the peritoneum, and here we found this adrenal vein that was found to be quite, large in diameter, and it very stuck to the adrenal tissue. We tried to mobilize the adrenal vein a little bit, but it was very stuck to the gland. So we decided to dissect the gland circumferentially to free up the whole gland and just have the adrenal vein attached so we could control safely with a stapler. So here, mobilize immediately and inferior. Then I create a tunnel under that large adrenal vein. So I see the tip of my instruments and I come in with the stapler. We put a number 1 trocar. It's had a good angle. As you can see, the rectech keeps coming to face because the liver was very bulky and we have very little space to work. I check the bite to make sure I'm not taking a side bite of the IVC, and then we're free. Take the last retroperitoneal attachments with the vessel sealer. You're good to go there. As you can see, the stapler line is a little over 1 centimeter. This next case is an obese patient, very bulky liver. As you can see, it can retract up. The liver is very thick. So we take the coronal ligaments and rotate the liver medially, and then you can see a little bit better the adrenal gland. In this case, I can show how we kind of control bleeding. There's a little vein on top of the adrenal vein. This was a pheochromocytoma very stuck, and then we got into a little bleeding, but we knew it was from the adrenal vein, not the IVC. So there is no reason to panic. We just put some rate tag, pressure, and wait a little bit. So every time you have this kind of bleeding, you have to have exposure. So we free the gland circumferentially off of the IVC so you can have a good exposure of the inferior vena cava in case you have to do any suturing or any stapling of that to control bleeding. So we mobilize inferior medially, the vessel sealer, then we go back to our site of bleeding. We remove the rate tag gently, so the bleeding by that time is already stopped. You can see there is a very small branch of the vein under that artery that was the source of bleeding. Go around with the scissors, control of the vessel sealer, and we're back to business. We go back and dissect cephalad to the adrenal vein, so we can see our tip from the bottom. Here we go, you can see the tip, so we're completely across and encircling the adrenal vein. In this case, we use a large hemolock because of the diameter of the vein. And we like to use the vessel sealer, so to have room, we mobilize cephalad. So we take some of the superior limb of the adrenal vein to get some length on the adrenal vein, and we take with the vessel sealer. Some retroperitoneal attachments there. Controlling a vessel sealer, the back muscles, get a good margin there. And the bleeding well controlled. So these cases, I think they're more complex. That's where the visualization and I think articulation helps. Now a quick video on the robotic left adrenalectomy. This is our routine. So we start mobilizing the spleen and the tail of the pancreas medially. You can see the tail of the pancreas coming to view. We go inferior to that and then rotate that medially. And then continue our dissection, the inferior phrenic ligament until we see the stomach. And here you see the gastric fundus kind of attached to the adrenal gland. So we start to mobilize the adrenal gland off the stomach. So we can open the book technique like described for laparoscopy. So keep it mobilized immediately. And then when we go around the inferior of the inferior limb of the adrenal vein, the adrenal gland, usually we can find the adrenal vein right there. And we control in the similar fashion with a hemolock towards the renal vein and then a vessel sealer on top. And then it's just mobilizing retroperitoneal attachments and freeing the circumferentially the gland. In the last video here, I show you It's a patient who had a very high splenic flexure, actually was under the spleen all the way to the diaphragm. So we had to kind of cautiously dissect, and the visualization helps to not confuse that with retroperitoneum. So not only we had to take the splenic flexure, but also dissect the mesocolon of the transverse column of the adrenal gland. And you can see very clearly the difference of the fat of the mesentery with the retroperitoneal fat. And after we mobilize the mesocolon out of the way, we can see the adrenal gland. And then it's a standard operation. We kind of go immediately, opening the book. Inferiorly, we find the adrenal vein controlled in the standard fashion with hemolock and vessel sealer. And then it's just dissect circumferentially with the vessel sealer of the kidney. Here, just careful with the stomach, because when we do a lateral retraction, sometimes the gastric fundus come with the gland. And then we extraction with the catch bag. So this is our experience. Hopefully it was helpful. And thank you very much for listening. And here's my email if you have any questions or want to reach out to help to set up your program. I'm happy to discuss and help. Thank you very much.
Well, thank you, Dr. Magawa. That was this beautiful, beautiful videotapes. But we'll have some questions in the Q&A there for you to answer, and we'll come back to it when we have time. Next up is laparoscopic retroperitoneal approach. This will be with Dr. Tomas Yamashita, also from Emory. Dr. Yamashita.
Yes, sir. Felipe, can you unshare your screen?
Absolutely. Sorry about that.
All right, let me just pull it up here. Can everyone see it? All right. So I'll be talking about posterior retroperitoneal adrenalectomy. I'd like to thank everyone. This is such a cool thing to be talking about. It's actually a procedure that I like a lot. So it's actually, I enjoy this a lot. So thank you for the SSAT for the opportunity. I have no disclosures. So the goal for this is not to make it comprehensive of, we're all retroperitoneal surgeons after this, but it's an introduction of what is it? Why should we do something different when we're all general surgeons trained to go through the front of the belly? Why are we doing something from the back, something that makes a little bit different? But why do it, when to do it, and how to do it? So the posterior retroperitoneal adrenalectomy, it's a minimally invasive approach. It gives you direct access to the retroperitoneum, avoiding peritoneal violation. It can be done either lateral or posterior approach. And I'll be talking to the posterior approach. It could be done robotically or laparoscopically. I do it laparoscopically and am in amidst performing it robotically. But this is what it looks like. So the patient is fully prone. Now, before we talk about the procedure stuff, I think it's always a little shout out to how they came up with it. And I will say, although a endocrine trained general surgeon, urology had the first reports on retroperitoneal minimally invasive exploration in 1993. Merkin and colleagues then start working in 1994. And Martin Maltz from Germany is the big forefather of the PRA as we know it, and has the longest and most complete, the biggest number for PRAs that we have. And it's someone who has been teaching many people around the world for it. So he deserves a shout out for this. But why do we do this? Why do something completely different? So I think the first pro is that there's no peritoneal violation, right? So at that point, we're avoiding any future problems for any future surgery, which is an important consideration for people who have genetic syndromes. As talked in many of the talks today, many of the people who have adrenal disorder that requires surgery have genetic syndromes that may require other adrenal surgeries or other abdominal surgeries, whether VHL, MEN, or other of the other diseases. It's something that you keep the abdominal cavity, the peritoneum virgin for it. It avoids the reoperative field, and in case of a frozen abdomen, it's the perfect approach. My first adrenal as a staff was a person with an active intracutaneous fistula with Cushing's disease that had a frozen abdomen. So that's the type of patient that, although you don't want it to be your first case ever, it's a perfect case for you to do this from the back because you're avoiding any issues with it in the future. One of the other parts of it that is pretty neat is that in the retroperitoneum, patients can tolerate a higher retroperitoneal pressure. So unlike the abdomen that we do around 15 millimeters of mercury, we can up to 20, up to 25. So not only there's a little bit of less bleeding, but also from a hemodynamic and cardiovascular tolerance of the patient, although prone, that is usually better tolerated. It does have a direct approach to the target gland, so you don't have to mobilize any organs around it. Your target, as soon as you put in the ports, you localize your anatomy. You don't need to mobilize and take anything out of the way, just the retroperitoneal fat, which with BMI, we know that can be quite a bit. And in case of the bilateral patient that need bilateral adrenalectomy, or if you do a cortical sparing or whatever you want to do, you don't need to reposition them. So just a significant amount of saving time on your turnover. Now, what are the cons? What are the things that we think about? Now, proning. We know that when the OR staff hears the words, oh, we're doing prone, they all love it, right? It's a pain. We know there's a lot of logistics with that. So that's something to keep in mind. It is an abnormal view. We're not used to seeing things flip, both from antero-posterior, but also medial-lateral. So where the kidney is, where IVC will be, where the liver is, where the peritoneum is, all of that is a somewhat unfamiliar and uneasy view, which kind of twists our head a little bit when we're doing the procedure. That's something to keep in mind. Because of that, and because of such a tight space, the bailout in case of an emergency is not as simple as just opening, right? If we're doing anything anteriorly, whichever approach you would like, we know that you can open and do a laparotomy. From the back, that's not the easiest thing to do. So the bailout can be a logistical nightmare for that. Whether it's a hand port, a stapler, suturing from the back, flank exploration, or flipping on an emergent table, those are all things that you have to think about and have talked extensively with the team and have all that planned out from the beginning and make sure that everyone is comfortable with the steps. Because when things are happening, there's no time for really dilly-dally of what's happening. It's fast. And it comes with a learning curve because of the unusual anatomy and approach. So I think the curve for learning the procedure is a little bit longer than the anterior approach because of how our training is. We're not used to having that vision or operating that way. The analogy that I tell the trainees and our fellows is that it's similar to extraperitoneal hernia repair. It's a small space, it's a different view, and the ports are usually fighting each other a little bit. So once you learn how to do it, I think it's a great procedure, but it's many times not the most ergonomic procedure to see someone do. Now, what are the indications? The same as transabdominal. There's nothing different from that perspective. The holes. People used to say that within 6 to 8 centimeters, that's when you should talking about differently. I will argue that that's also very surgeon dependent on comfort level of what can you do. I'm very conservative on needing to open or just doing, and depending on size, that's just something that there's no hard indication for that. But there's definitely contraindications and things to keep in mind. Severe obesity in our training centers are usually something that we keep in mind. Most surgeons talk about BMI of over 35 being a little bit difficult, not only because of the positioning and the apparatus that you need to put the patient on maybe not fit, but also because of the retroperitoneal amount of fat they're going to have. So it kind of can be somewhat frustrating when you're digging through all that, trying to find the adrenal gland. That being said, depending on where you're from, where I trained for fellowship, that was the approach. And we did it on patients with BMI of 40, 45. So it's really what you want to do. It's not a hard contraindication. Known and suspected ACC, as discussed before, we know that you don't want to disrupt the capsule, so that's something that you should be very mindful. And the large tumors and local regional invasion, I think, similar to the anterior approach, it goes to how able are you and what is your skill level and why you can do something. And although guidelines do say, for those things you should be open to decrease recurrence and things like that, there's surgeons who do this posterior and do an amazing job. So I don't think it's a hard indication, but it's not a case that everyone should be doing that approach. In case of unfavorable anatomy, so patients that have are unable to be prone, patients that have a small space between the costal margin and the rib, patients that have any skin issues in the past, patients with very broad paraspinous musculature that don't have the space. So that's just something that in clinic we have to be mindful when assessing. Now, what are the complications and how do we talk about them? Overall, there's in literature a conversion rate either to an anterior approach or to an open approach of about 2%, major complication of 1.7%, and minor complication of 14%. I will say that those are hyperinflated by relatively clinically insignificant complications, such as subcutaneous emphysema because of the high pressure that we put on the retroperitoneum. So I will say it would actually be lower than that, but that's what is in the literature. bleeding, infection, pneumothorax because of the high pressure, and you can pop into the chest depending on where you are when you are putting the trocars in. Subcutaneous emphysema, alteration of flag, neuralgia and paresthesia because of the abdominal wall and when the nerves are. That being said, in the complication side, as I mentioned before, having talked to the team, having talked to anesthesia, having a hand port, a stapler, a stitch, pressure, all those things are important for this case because it's not a easy bailout in case of an emergency or a bleed. But how do we do it? So this is the position that we do. I personally am using the Wilson frame. There's a Cloward settle that can be done as well. The patient is prone or patient is induced supine, lined up, get everything done, then we flip him and mark him. The first incision is a 12 mm incision that will be around below the 12th rib. You do blunt and sharp dissection down the retroperitoneum. And this is actually one of the scariest maneuvers, I think, in endocrine surgery, that you pop in blindly by feel with the heavy curved Mayo scissors. So you go in, feel it where it is, you're going to feel the rib, and then under your own finger, you're going to put a medial and a lateral port, which can be a 10 or a 5 mm depending on the space. Traditionally, a 10 medial and a 5 lateral. You're going to use a 5 or 10 mm 30-degree scope, depending on what you have in the space. And as I mentioned, the insufflation, I use AirSeal at 20 to help control, but you can go up to 25. The only thing is you have to tell anesthesia about the hypercarbia, which may not be tolerated. So that's why the constant communication with the team. But this is the position. Now, I'm going to show a couple of small pictures of what it is before I show some videos, just because of the unfamiliarity. So when you first get in, the first part is exploring the retroperitoneum. So you're going to find some fat, you're going to find gerodas. That's a combination of blunt and sharp dissection, peanut, suction, harmonic until you open it. Once you're in that plane, you're going to see gerodas tear, and in between, you're going to see then the amount of fat as well. And you're still looking for the anatomic structures that help you to delineate where to go. The first one, immediately you're going to see the paraspinous muscles, laterally see the peritoneal reflection, and inferiorly the kidney. And those are the borders for your safety where you're doing dissection. If you're not finding any of those, you should take a step back and reassess to make sure you know where you are, because you can easily get into either intra-abdominally, you can injure the renal hilum, and that's why the patient, the higher BMI, the higher amount of retroperitoneal fat can be a more challenging case because of that. Once those have been identified, you proceed with the dissection immediately up to the diaphragm. You proceed it laterally as well. And once all that is done, you're going to leave a superior attachment that's going to keep on the adrenal gland hanging up. And this way, just not falling in her face. Finding the kidney, you can continue the dissection cranially. You find the vein just like as you would on the anterior approach, whichever clip you would like to do, and enjoy the dissection surrounding. So the first case I'm going to present, this is a 49-year-old gentleman with a pheochromocytoma, 6.2 centimeters. He's been blocked. He was taken to the OR for transabdominal, but due to multiple adhesions for multiple surgeries in infancy, they were unable to proceed. The team contacted me, and then in the same admission, I assessed him and were able to do this retroperitoneoscopically. So we can see a very large tumor on the scan, pretty superior, pretty medial there. I'm going to start on the video here. I apologize. It's a little fast just because I want to get a couple of points. So before I play the video, this is already gerodas being spread out and open. So you can see the fibers and underneath the fat showing up. And there's a lot of blunt dissection happening. I'm going to pause there. Medially, you see that red. That is paraspinous muscle, and that's the medial border of our dissection. So once you found that, you can keep on freeing things up cranially until you find it. Now, I pause here again because this is peritoneal reflection. This is the lateral. I'd like to think this as a pyramid, which on the medial side, you have paraspinals. On the lateral side, you're going to see the peritoneal reflection. The base of it is going to be the kidney. And the tip is what you don't want to take because that's the fat that is keeping the adrenal up because otherwise it'll be flopping around you. So I keep on the dissection with the peanut, with the harmonic, slowly gearing up. I'm going to pause here a little bit. Sorry, I jumped a couple of steps there just because of time perspective. So adrenal's already identified. And then here I'm freeing up the medial limb, which is coming off of the IVC. And I think that's the portion that I like the most about this case because I think the IVC dissection. So we see the IVC fully collapse there because of the pressure. And it's actually, even if you bled, it's something that's relatively easy to control at that level of pressure. So it's fully collapsed, so it's easy to mistake. I have the adrenal vein in view fully there. I'm just cleaning it up around it to get the perfect angle to then get the clip. The kidney keeps on getting up, so you have to go underneath it and push that down, which is what I was doing there, and just keep getting on the adrenal vein. Similarly, as I mentioned before, the vein can be taken with whichever clips you want. I do 2 clips on the stay side and take with the harmonic. You can see the tumor right underneath my grasper there, the gentle pushing on it because it is a pheochromocytoma. And what you saw there was me struggling just with the ports a little bit, and there's a little bit of sword fighting. So I wanted to keep that in because that's one of the difficulties in this procedure. It's a very tight space. The ports are placed usually in line, and just some difficulty with some relative sword fighting and the angle. So whoever is running the camera has also have had some experience and be a pretty good camera driver. I'm going to expedite a little bit because of time. Here's just me taking the other retroperitoneal approaches inferiorly. So we have most of the adrenal gland already free up, a little bit on the medial portion here, a little bit of attachment to the paraspinous. The second case I'm going to present, this is a 49-year-old gentleman with a new pheo. So he has a history of von Hippel-Lindau, had a prior left adrenalectomy, but was found to have a new pheochromocytoma on the right. Unfortunately, that was on the medial and very superior aspect of it, as you can see on the scan and the arrow, which makes cortical sparing somewhat challenging in order to preserve the vein. I think this is something that anteriorly I would not have been able to do to save the vein. I think posteriorly gave me direct access to it for the cortical sparing, especially in this case. Now, video here we're already in. I've already opened Girota's. What you see on the right side of the grasper, that will be where the tumor will be. Immediately the red, that is paraspinous muscle, and that's just some attachments that I'm taking. And what you're seeing is there, like the tumor is already in sight. And this is a little bit of a different case because I've not done the full dissection that I do medial, lateral, and from the kidney, because I'm trying to disrupt as little as I can from the remnant adrenal to preserve it and decrease the risk of adrenal insufficiency. So in this one, I'm not going to try to find the vein to take it, but I'm going to try to find the tumor and take as little adrenal as I can without disrupting it. So it's also a somewhat scary thing to be doing on the IVC. As we're going there, taking some of the vessels there, a little bit more of the dissection has been done. So now you can see the tumor right there with some normal adrenal around it. I'm lifting up as little as I can from the medial limb there just to get me the gauge around it. Because the other part of it is I don't want to do all this and then have a positive margin and have it recur, right? I think for all these patients, especially with the cortical sparings, I do tell them that if a cortical sparing is going to compromise their oncologic outcome, I will do a total and they're going to be adrenal insufficient for life. Because what you don't want is then having to come back for recurrence on an operated view because of your remnant disease that you left. So we see obviously a tumor right there, some normal adrenal. And I'm going to skip a little bit to where I'm starting to take the disease or doing the wedge resection. So trying to get some grasp, a little bit difficult there because I didn't leave any tissue for me to have a little handle. But once I get the angle, you can see the IVC not fully dissected on the back right there, also collapsed. I start taking it with the harmonic and just go across it. Some people do with the ligature. I prefer the harmonic because I think for bleeding it bleeds less, but also staple is appropriate, which is why the 12 port is the only port that I'm not giving up on a size perspective, because in case of an emergency, you have case for a staple. So here's the full removal of the wedge of the adrenal gland. So in conclusion, I know I talk very fast and this was what I'm trying to make up for the time, so I apologize. I do think that PRA is an excellent approach, but familiarity with the procedure is critical. You do need to have a good team and good communication, and it can be a logistical nightmare until the team is at ease at it. And it's your job as a surgeon leader of that to be able to walk people through it and have the plan A, B, C, D, E, F, G through Z spelled out both to anesthesia, nurses, and everyone, so everyone's aware of what to do next if you have an intraoperative complication, or if you're unable to proceed, if you're going to flip, if you're going to open, what you would do. And I do think that it does allow you to operate and select patients that anterior approach will be less than ideal. Once again, I'd like to thank for the opportunity. I'd be happy to take any questions.
Oh, thank you, Dr. Yamashita. That was a beautiful presentation. We have about 6-7 minutes, and I can, there are multiple questions in the question box there. Some of them have been answered. I want to pose a question that's commonly asked, basically related to, obviously, and this is a question for everybody, for Dr. Yamashita and for Dr. Magawa, and actually probably also for Dr. Yip. So obviously, when we do these operations, we worry about the technical problems of bleeding, which is one of the major things we always worry about. But what about a tumor that Dr. Yip showed that is possibly cancer, but we don't know that for sure? Let's say a 20 or 30% chance it may be cancers. So do you still do that with the approaches that you do? Maybe I can get some comments from Dr. Yip and then some comments from Dr. Magawa about how robotically you may handle that case. And then from Dr. Yamashita, how do you take care of something that could be a cancer? And they say, well, maybe you should do it open, maybe you should not, depending on how good you are. So I'd just like to hear comments from all of you. Let's start with Dr. Yip.
Yeah, that's a great question. I think I think no matter what, you have to maintain oncologic principles. So I think if you're planning on taking out something that's potentially malignant, you have to, number one, make sure that you don't get in the capsule, and number two, make sure that you can get a nice margin. So if for some reason it's involving some adjacent organ, that you have the capability of being able to get that margin. And so I think it depends on every surgeon's comfort level in terms of whether or not they feel like they can do this minimally invasive versus open. I think in any decision to do minimally invasive, then you have to be ready to open if for some reason you have an issue. But I think making sure that you do not get in the capsule is so important. If you even suspect cancer is a possibility, because that really affects your oncologic outcome in the future.
Well, Dr. Magawa, I assume you do these robotically, but what's your limit? How aggressively do you go after these with minimally invasive operation?
So I agree with Dr. Yip. We have to respect the oncological principles. You look at the preoperative image, and if you see a fat plane between, like a vital structure, like celiac trunk on the left or the IVC, and you can do that robotically, respecting your margins and in an oncological way, then you can do it laparoscopic or robotic. But I think if you're concerned of invasion of, then it depends on your comfort level to do some reconstruction, minimally invasive. For the bigger tumors, I still think open. Anything more than 10 centimeters, in my experience, we prefer to go open, because I think it's a retroperitoneal tumor. Will be stuck to the retroperitoneal structures. So I think if you don't have the skill set to do a IVC reconstruction, then I think you're better off doing open, and then have a good outcome oncologically for the patient.
Dr. Yamashita?
Yeah. And I think that's one of the biggest conundrums for every surgeon when you're talking to the patient, those indeterminate nodules or indeterminate masses. I think very patient-centered, I think, as both Dr. Mega and Dr. Yip have discussed. I think for the smaller lesions, I think I've been more doing on the PRA. I think that if there's any issues, I would flip. But if they're on the bigger side, personally, I'm very conservative. I would do that anterior. I think that if you're having to open or having any issues, I think for better oncologic outcomes in my hands, I would do the anterior because of laparotomy. But I think it just depends on how you manage it and what you are looking into. But I think it's a big conversation with the patient. And then in the clinic, it's very important that you tell them that you're going to do as little as you need to give them the best operation, whether that is open, whether that is a conversion, whether that is a bigger operation.
Related to, maybe you can answer this first, since you did that subtotal resection. What are the indications for subtotal resection, and what do you worry about? I want everybody on the panel to chime in on this, but you go first.
Yeah, absolutely. So the subtotal resection, I think there's two bigger groups of patients that we think about. I think the first one are the people who with genetic syndromes with bilateral disease. So bilateral fields, MEN, VHL, such as the patient that I talked in my presented the video. I think that's a population you're trying to preserve as much cortis as you can. And I think not only you have the concern for disease recurrence and disease or leaving disease behind if you're trying to spare too much, but the adrenal insufficiency. So it's weighing how much you want to take and what is the safety of your procedure and how much disease you may leave behind. So that's why I think also letting them know ahead of time that if a cortical sparing is unable to be done, that you might have to do a bilateral. And I think that's something to keep in mind. And I think the other population that a subtotal may be beneficial are the bilateral Cushings from a debulking of cortisol production and trying to improve their comorbidities and sometimes even improve their life quality from it. I think there's a lot of discussion. That's a very controversial topic if you're going to do one side or do a subtotal or do a partial in the future. I personally do the biggest side, and then I leave to do corticospray in the future if needed. I don't do a subtotal immediately, but I know there's plenty of people who do. So I think that's a population that
And since you mentioned that, let's have Dr. Ramirez chime in on this, because you were the one that presented on hypercortisolism. What's the role of subtotal resection in hypercortisolism?
I personally have not done a subtotal in hypercortisolism. I think that what I really have seen is when you have the likelihood of for example, if your AVS comes back and you do have evidence of bilateral secretion, the general consensus would be to try to remove as kind of a debulking type procedure, the larger side first. What I have seen is people will pause there, see if there's any improvement. Potentially they get some durability even for a short period of time, 2-3 years, before then the disease can recur, but maybe not as medically refractory, so possibly easier to control medically in that case, and then question whether surgery would be needed at that time. But then if it does go down that road, that's where I could see the possibility of doing a subtotal and it being kind of beneficial. I think my experience in ectopic ACTH producing tumors didn't leave any room for subtotal in that scenario.
I think in general, subtotal resection for cortisol secreting issues, it tend to be limited. But what about your thought, Dr. Patel?
I think I agree with Adriana. I think part of it is you always want to start with one side and the higher side. And that's what we've done traditionally, and then see how they respond before attacking the other side and doing subtotal. So you'll often see a response just from that one side, just based on the AVS or the larger side.
Well, our time is basically almost up. We can continue, and there's actually still some other questions in the question box that have not been answered, and I'm going to let you have a chance to go after it. And I think Beverly's going to have to tell us when to stop. I mean, we can keep going on and on and on. One of my pet peeves is related to what Dr. Yip says, that you should not spill a tumor, even something that you think may be benign, because if you spill tumor, they will grow, even the benign ones. And so you do have to be careful with that. So do we have more questions? There's actually lots of different questions in there about the robot, and there's a question about how we extract the large non-functioning tumors. So maybe we just go through very quickly. How do you take the tumor out? You make the incision bigger, you put it in the bag and break it up. How do you do it? Let's start with you, Dr. Patel.
Yeah, that's a great question. I think that's what you were kind of talking about, leaving it intact. So we put it in a bag, and then we are having to make the incision bigger because you want to leave it in. We like to leave it intact and not fracture it. So we have the entire specimen for margins.
So your pathologist does not get mad at you.
Exactly.
Anybody else will break up your tumor to take it out? Okay, so I may be one of the exceptions. I actually do. For fields, yes, you want the margin. For ACCs. For things that's possibly cancer, I would tend to leave it. But, an adult patient, I don't really care if that lesion is intact, because you take the whole thing out anyway. But Any other thoughts about whether or not you break up the tumor? No. Okay, so that answers that question. I think we better stop. This has been extremely a great webinar. Thank you everyone for contributing to this. We review how you work up incidentalloma, how to deal with pheochromocytoma, how to deal with hypercortisolism, hyperaldosteronism, and a great experience with those beautiful robotic tape, and also the retroperitoneal tape. So again, thank you very much, everyone, and I think we will conclude this, and maybe the panelists can just stay on so I can thank you individually. And I guess it's up to Bev to cut this off.